So without further ado, let me invite the chair of this session, Dr. Faisal Sultan, if you could kindly come and join us on the stage. He needs no introduction. I would also like to invite Dr. Abdul Jalil Khan, who is a consultant family physician with over 16 years of experience working in NHS UK. He is currently working as an assistant professor of family medicine at KMU. He is a fellow of Royal College of General Practitioners of UK and fellow of AG Higher Education Academy in UK. So if you could kindly come and join us on stage. Next, Professor Marie Andrades. Professor Andrades is Head of Department of Family Medicine at Jinnah Sindh Medical University. She's a Fellow of College of Physicians and Surgeons, Cpsp, Fellow of Royal College of General Practitioners, UK, and has a master's degree in Health Profession Education from AKU. If she could kindly come and join us on stage. Our second panelist is Professor Adil Heder. He is Dean of AKU Medical College University. He is also an AKU alumnus and holds a master's degree in public health from Johns Hopkins School of Public Health. He's practicing trauma and acute care surgeon. And I knew him when he was at Brigham and Women in Boston. Thank you. I would also like to invite Professor Asha Javed, Vice Chancellor of Pebble Medical University. Professor Javed was #1 in the merit list prepared by search committee. He brings with him rich administrative experience as he has served as Chief Executive of Lady Reading Hospital for many years. Recently, he was Dean of Postgraduate Medical Institute at LRH. He's an eminent pulmonary medicine specialist. So how the session will run is Dr. Jalil Khan will give a 15-minute talk. Then we will have, after that we'll have opening comments from the session chair for about 3 minutes, and each panelist will give their impression for 2 minutes. Then we'll open it up for question answers. So if I could request Professor Jalil Khan.
Bismillahirrahmanirrahim. As I said, my name is Dr. Jalil Khan. I'm Assistant Professor of Family Medicine at Heder Medical University, Peshawar. I welcome you all. I would rather say, all my teachers and my colleagues and faculty and dear students. When we started talking about family medicine, that was 2 years ago when we used to come to Pakistan as UK trained physician, family physician, who wanted to bring family practice in Pakistan. At that time, as Faisal mentioned earlier, that we've been always told these people who came from abroad, they don't know the ground reality. So we had the same problem. But now, alhamdulillah, if you look at the talk today, so today we are not talking about that there is a need for family medicine. Today we are talking about that this is Pakistan's critical need. So now I don't need to explain what is family medicine, why is it important, why do we need it for a comprehensive primary health care force to be run by family physicians. So we don't need to talk about it. The message is very loud and clear, and I've already been told this morning by all our distinguished speakers. So most of you sitting here now already know that 70% of the healthcare problems are related to primary healthcare problem. But we are all investing on tertiary care, secondary care, as you may all know. So where is the problem? So that's what we're going to talk now. So if you look at the situation in Pakistan, And our Honorable Prime Minister, his vision for the next 5 years, again, we did talk about it for the universal health coverage. So the aim is every citizen of Pakistan should have an access to quality service without financial hardship. And that's the next 5 years plan. So we only got 5 years to achieve that. Now, how are we going to achieve it? Again, a family practice approach. Because if we are going on and on and on and investing in tertiary care hospital, I just give you one example. In Peshawar, there is a very big neurosurgery unit in tertiary care hospital in LRH. But because we are so tertiary care focused, all of a sudden we decided to build a neurosurgery ward in a satellite hospital which is only like 2 kilometer maybe radius mile, and a cardiology units again in the same satellite hospital. So do we really need that? Because LRH is only a kilometer away. Because we are only focused on tertiary care. But then what's happening there now? There's a big neurosurgery unit with a consultant, with medical officers, nurses, technicians, everybody. But they can't operate because they haven't got a neuro ICU. So which means the money has gone wasted. If that money would have been spent on building primary care unit around and near the radius of Lady Raining Hospital, which is our big tertiary hospital in the area, and most of the 60-70% primary care problem which are ending up in emergency department of LRH, that would have been cared for within them satellite hospital, and only 10-20% who actually need referral or who need secondary or tertiary care intervention, only them would have been referred. So how much money would have been saving that? Anyway, that's our government plan. So now we need to really start thinking about the most cost-effective model. How are we going to do that? Again, this morning most of the talks were about this. So if you look at the healthcare delivery pyramid in our country, so it's mostly tertiary healthcare. 70% of people, despite having primary care problems, they're still going to tertiary hospitals. And primary care is only a little bit of that. What we need to do is, through family practice approach, we need to invert that pyramid. So the 70% should be covered by primary care, and tertiary care, only those problems which really need a tertiary care intervention, only them need to be referred there. Now, how are we going to do that? If you look at it, these are some key dates, remember them. 1992, what we did? Family medicine training has been approved by the College of Physicians and Surgeons of Pakistan. Where are we now? 2020. And we're still talking about that is, despite knowing there is Pakistan critical need, how many FCPS we've got. I will give you the numbers as well. In 1993, Aga Khan University Hospital started the FCPS programs. 2020, approximate number of FCPS training. This is still a bit exaggeration because I made the number 100, but Unap knows it's not even 100. I think it's 90 something? 67. Or I think it's in 90s. Yeah? Okay, on the top, you can add few of us, the expats who returned back to Pakistan, MRCGP, FRCGP, UK. So let's suppose we are 100. These are the only faculty who will be allowed to train any trainee. Only these people can supervise, which Zafar Saab said 150,000 GPs we need. So even if we are 100, we have to train 150,000. So that's what we need. So that's the target for all my experts sitting here. Now, if you look at the speed we are going, so these are all programs of family medicine in Pakistan. So if you look, even if you include the diploma, 1 year, master, MD, FCPS, everything, even that is still not more than 1,000. And bear in mind, what we are doing, we are training them, but then they are heading off to Gulf. So that's what we are doing. Because there is no job opportunity, there is no incentive for family physician. Now, how are we going to tackle that? That's why the experts are sitting there. And I'm just going to put a few simple questions in front of them. And if you all agree, then we're going to ask them. So this is a UK model, yeah? This is my surgery in UK, but the Mercedes doesn't belong to me, that belongs to my practice nurse. So just imagine, my practice nurse got that Mercedes. Then if you look at it, that's when I'm used to do out-of-hour shift. So I've got a blue light car. So I'm allowed to break the signal. I'm a GP. I specialize in awesomeness. That's why I've got that blue light car. I can do that. So the UK model is purchaser and provider. Yeah? So we have to buy the service from the specialist hospital. So the specialist hospitals, unless we recommend how many number of clinicians they need, how many number of specialists they're going to have, how many hernias, elective surgeries we're going to refer to these consultants, that's not going to be possible because we sit on the clinical commission, clinical governance boards. Again, it's a performance-based payment. So if we perform good quality work, like all my patients, if they have a better HbA1c control, at least 95% of my patients, if they are within the target, I get paid 1% extra. If I don't do that, so it's not only a carrot, there is a stick. I also work for Care Quality Commission UK, and we do quality inspections. And that inspection is, I know when my colleagues who are trained from UK, when they see me, so they normally say like, you know, you don't sound that scary, but when you come on inspections, you are quite scared, because that's what we do. We just monitor them completely. How is their service effective? Is it accessible? Is it responsive? Or is it caring? That's how we assess them. So it's not only the money, because we have to assess them as well. If you look at the Gulf model, again, they're not that clever, but they got money. So what they did, they imported a lot of GPs. Most of them are UK trained, but they are Pakistani origin. And trust me, if people sitting here create an environment, all these 200 plus GPs who are working in Qatar, I personally can take the responsibility to bring at least half of them back to Pakistan. And the reason they are ready, if you want to see an example, I went to Qatar, but then I decided if I'm going to do something for them, why not for our people? And me and Kashif, and we got a faculty of 3 people in KMU, and I'm sure like, you know, other hospitals have got it as well now. Faisal is here from Bakai and a lot of people. So it's doable. But how is it not going to be doable? The problem is the problem because of our attitude? There are 2 types of attitude. I'm not going to say which one we got. I will let you decide. One is Middle Eastern attitude. Wallahi, if one can do it, let him do it. If no one can do it, ya Habibi, how can I do it? But then, there is a Japanese attitude. If one can do it, I can do it. If no one can do it, I must do it. And that's what we need to do. Now let's see what these GPs are asking for, what these primary physicians are asking for. So do we really need to incentivize them? Do we need money? What do we need? What exactly they want? Although I haven't got much experience, I've been working 18 months in Pakistan now. But during that 18 months, our Vice Chancellor, Professor Javed, is sitting here. We, alhamdulillah, successfully run the program for 2 years. So what we learned from there? So you need to incentivize. But what incentive really they want? I've divided into 5 R's. Respect, recognition, and then reward or retention, and results. We are ready to give you the results. We only want you to give us the respect and the recognition. That's what we want. Now what these 5 R's we want during the training. So during the training, respect, recognition, retain. If you give me a respect same as other specialists, that's what I want. That's what I want. I don't want much. Training slots in family medicine, in tertiary care and primary care hospitals. Specialist TMOs, like any other specialty, to have a clinical rotation in primary healthcare centers. So then they realize the importance of it, and that's what happened everywhere in the world. Whenever you're training a pediatrician, a gynecologist, to have the community-based learning, they had to go. In Pakistan, we did try to start community-oriented medical education, but it failed. And the reason was because we haven't had a specialist trained family physician in the community. So that's what we want. And defining the boundaries, because sometimes I have to clarify myself. Am I a family physician, or what is the difference between internal medicine and family physician? I'm not going to explain that to you. I'm sure most of you know that. Recognition. So we're asking for what? National Directorate for Family Practice Approach. So there is a directorate. I'm sure Prime Minister Task Force people are sitting here, and they're going to discuss how they can incorporate the experts of family medicine physicians, the primary care physicians, the Association of GPs, how they can incorporate them into the that National Family Medicine Directorate, and each will be obviously given the task of doing their job. And then Family Medicine Specialist Cadre, which is at BHU RSC level. I will let the government decide that. Even if at RSC level you bring a physician who is a consultant and patient get registered under their name. Trust me, then we don't need to do any of these conferences. If the students here sitting here, if I manage to convince them that after 5-10 years, there will be 3,000 family physician consultant jobs in RSC level, most of them won't go to tertiary hospital because tertiary hospital is hectic, is busy, is risk of violence, everything. Well, RSC could be at their village level, it could be at their near to their house, and they may be able to do better job there. So most of them will most likely go there, providing they know that I'm also a consultant, I'm also a family physician consultant. And again, postgraduate training slot. Now obviously, once we train them, we want to retain them. Otherwise, what's going to happen? They're going to move away to Gulf. They're going to go to Australia. Even Australia had a consultative meeting with our Cpsp, and they wanted for our trainees to go there and do 2 years training there. Unfortunately, we haven't got part 1 enough FCPS trainees. But my worry would be, I send them to Australia, are they going to come back? This is my worry. But if you give us something, I can show it to them so they can come back. So job opportunities, choice of work area. In primary care, I belong to a tribal district far-flung called Movement. Now it's not called tribal area, it's a KP merged tribe, merged areas. But they're not going to send me to my village, but they're going to send me to another village 1,000 miles away. So what's the logic behind that? If you send them to their same area they belong from, they can go. And I'm sure National Task Force is on the job and they're already planning to do that with your domicile area. They're going to send you there. Legal bonds. We need to, because if we train them, if we incentivize them, then we have to have a bond that you're going to work for us for the next 5 to 10 years at least, and keep the same PhD for 5 years. That's the other thing. For continuity of care, you need to have then that same trained family physician in the same PhD for the next 5 years or 10 years at least, so they can provide care to their patient. Because that's another issue, like, you got a good doctor and then they got transferred. Okay, now, yes, we do need a bit of reward. So what reward we want for? You need to give us paid training. I can't convince these students to come and do an FCPS of 4 years once I find out that there are not enough training slot of FCPS for family physician in hospital. Okay, in hospital you may find a slot, but when they go for their 1-year family physician training, which is going to be at the moment most likely into these family experts, 100 of them, clinics, obviously the government need to pay them training. Because if it's not a paid training, nobody wants to do that, because most of the postgraduate trainees, they got a family to feed, they got children, young children, so obviously you need to incentivize that just like any other FCPS you do. Okay? Penalties for not having training, again, I'm not saying is give me everything and I'm not going to give you anything back to you. Yes, if you need the results, I will give you improvement in service delivery, better care, reduced referral. Already overburdened tertiary care system. What's happening? Everybody is going to Peshawar. There is a very famous, I know it's kind of joke, but people have put on the Facebook that a patient is ringing the hospital. What do you want me to do from a district? Shall I come to the hospital to get a check over? Or can I Peshawar ki gaadi mein seedha baith jaऊं, chala jaऊं? So that's what they ask from the district hospital. Shall I sit straight into the Peshawar ki gaadi to go to Peshawar, or do I need to come and you're going to provide me care at my doorstep? So we're going to then definitely give you the results. Now, once they complete the training, what are they asking for then? Again, not much. The same respect. I've gone results there first, but anyway, I want results from the government as well, obviously. We're going to train these people, and your results you're going to give us to whether it's been implemented or not. Recognition and retain. What, again, same as other specialists. Clinical supervisor role for these MCPS, FCPS, whoever going to run and work as a family medicine specialist in these BHUs and RHCs. And again, defining the boundaries, because some hospitals have started family medicine departments as well. So then you have to define the boundaries, what the general medicine people are going to do, what the family medicine people are going to do. And again, we don't need to go into the detail. We can There's already clear-cut definitions. We can help you with that. And I think in this hospital, some other hospitals are already doing it. And again, family medicine specialists schedule role in BHUs, RHCs. Family medicine be included in undergraduate curriculum. This is the most important step. And the reason I'm saying it because if you include this in undergraduate curriculum, students will get to know that there is a specialty called family medicine and they would like to come to this specialty. Plus, the university and the hospital will create faculty jobs. And once the faculty jobs are created, you increase the demand. You increase the demand, then people will show interest and they will start doing post-graduation in family medicine. It's as simple as it is. Again, we did talk about job opportunities, faculty positions, district specialist jobs in family medicine. I think for the government is not a big issue. A lot of doctors get promoted to grade 18 even if they don't do anything. You spend there 10 years, from 17 you get 18, that's fine. So why a person who have done MCPS, even a diploma, FCPS again, normally they do get faculty jobs, although there are not many. Why these people, we can't put them into jobs as a district family medicine specialist? Trust me, if you do that, you will solve a lot of problems. In a lot of category D hospitals, there are empty slots of district medical specialists because after FCPS medicine, after FCPS peds, after FCPS surgery, nobody wants to go to periphery. This is the situation. But if you, even them unoccupied slots, you give them to a person who has done MCPS in family medicine and say, look, I give you that respect. From now onward, you are a district specialist in family medicine and you go into that hospital. He can deal with the children problems. He can deal with the gynae problems you're going to deal at RSC levels. You don't need an FCPS in gynae for that. He can deal with the medical problems, whatever present there. And he's still a specialist because he specialized in patients. A cardiologist is a specialist of heart. A neurologist is a specialist of brain. While the family physician is the specialist of patient. Yeah? So that's what we're asking for. Now, again, give us better salary package. If you want to retain us there, if you're going to send me to Chitral, obviously my kids, I then have to have two houses, isn't it? My kids going to be in Peshawar. They need to have a school. I have to come every weekend or every other weekend. So a bit of better salary package. Again, I'm sure in KP they have already started. Even the medical officer in KP are getting better paid than we assistant professor because they call some special payment where people are working in far-flung areas. So they've already started that. So that's not a big deal. Performance-based payment. This is another thing. Give me a target. If I'm able to register the patient of diabetes, hypertension, NCD, and all that money you're going to put in NCDs from NGOs, from the government, give that to that family care physician, and they will be able to provide better care, but with a quality control. Again, I'm sure in KP we got HCC, we got IMU, monitoring people are there, and they can come and have a check on me. So that's doable. That's not something which is not doable. Again, you've allowed them to do institutional-based private practice at the hospital. Why can't a family physician who is working in RHC can do a evening private practice in the same RHC? Again, your problem of keeping them open till late going to be sorted. I'm sure a lot of you may not want to do IBP, but trust me, in KP they have practiced it. I went to the HMC, which is the hospital associated with our university, Hyderabad Medical Complex. Their IBP practice was chock-a-block. There was a lot of patients. The consultants are now quite happy. So they can do that. So that's not an issue. So then definitely, yes, we're going to give you results, improvement in service delivery, better care, reduce referral, increase patient trust. Now, a lot of people are complaining that unless the medicine is there, nobody wants to come. Then, even if the medicine is not there, because they still come to your private clinic where you charge them, but they're not ready to come to BHU and RHC. Why? Because of lack of trust. Because their understanding is that in the BHU, either even that doctor who have just finished his medical school and came out, who is now learning on me, even that doctor is not going to be present. Or a medical technician, not even a nurse. The nurses are now qualified, graduate and everything. Again, we're going to talk tomorrow about how we can improve nursing care, how can we deliver, start other cadres like nursing practitioners, or because they can have a big role as well. So that's what we're going to do. And it's not a rocket science, it's been happening. In America, there is an associate physician role, people are doing it. but that all of them should be under the supervision of that family medicine specialist. Now, again, we're not going to take too long because these are my questions on your behalf to the panel, and I will let them decide if they are ready to give us that respect and recognition or not. Implementation, simple. Now, we need sponsorship and ownership from the government or from the health department. That's what we need. Identify the upgraded primary healthcare centers. So you can upgrade only a few of the RHCs and implement the family practice model there. Again, we know there could be restraint of money, there could be restraint of workforce, but you can identify few primary healthcare facilities and you can link them to the hospital with an electronic referral system, electronic patient record system. Incentivize those who have completed the training. So basically, now I've learned the government terminologies because we were asking for it. Now they call it a family medicine cadre. So if they create a new cadre called family medicine specialist, that's the solution, so they can do that. Family physician posts should be at RHC levels and even BHU levels. Family practice approach, again, it should be implemented in every district. So again, like in KP, if we are doing something different, you guys are doing something different, in Sindh they're doing something different. So we need to have a uniform system. I'm sure like, a lot of people are already doing it, like at their own level, but that's what we need. Yeah, so before I say that, a lot of people would say, because although we haven't got an integrated approach and it's a lot of disintegrated services, everybody is doing a bit at their level, which is still good. Because rather than complaining and moaning and thinking that whatever process these experts are going to give, it's not going to be implemented. We've been told when we were teaching consultation fees a lot of the time in Pakistan that, oh, Dr. Saab, these things can't happen in Pakistan. No. What we thought, शिकवाए जुल्मते शब से कहीं बेहतर था, शिकवाए जुल्मते शब से कहीं बेहतर था, अपने हिस्से की कोई शम्मा जलाते जाते. So even if you guys are doing it individually, any organization, you're already doing it. What we need to do is, we just need to come together at one platform. And special thanks to Ahmed Hassan and Professor Umar, they have given you the platform here. And again, last week, Professor Asha Javed Saab gave us a platform. All the experts came to Peshawar. Now we are in Pindi. Next time we can be in Lahore. Fourth time we can be in Karachi. That's what we need. So it's not a big task. So what we need, I'm going to finish now because I'm looking at the moderator trying to avoid because the time is running. Okay. So the question for the speaker is, are they asking for too much? If it's too much, yes, tell us, it's too much, we can't give. But what we want is recognition, we want respect from you, or rather you to get us that recognition and respect and reward from whoever are able. But again, Zafar Mirza Saab was here this morning and he did say, I'm ready to give you that. But we just need to push a little bit. So I want you to get us that respect, that recognition, and that reward. And trust me, what they're going to give you. They're going to give you the results, and I will be able to retain them in Pakistan and ensure that they're going to give you the results. That's what we want. So I think I should finish by this slide. So thank you very much. And it's up to the experts. I think they know how they can get us that respect and recognition. Thank you very much.
Thank you, Professor Jalil. Now I would like to invite the session chair, Dr. Faisal Sultan, to share his comments.
Thank you. I'll be very, very brief because we are short on time, and I think I'd rather have the panelists take the time and the time for discussions. But all I'll say is that I think the misalignment between what we desire and what we are willing to do for it is what's causing this. I think we need to align what we desire with the incentives and the recognition. And I think, as I mentioned briefly in my presentation as well, there is a great opportunity to use essentially a national health insurance that's been created, the Sehat card system, to eventually or perhaps sooner expand it to qualified general practice clinics. And I think that would start to change the fundamental incentives behind how society works as far as the healthcare part of it is concerned. But let's look forward to some of the discussion.
Thank you, Dr. Sultan, Dr. Maria.
Okay, so thank you so much for organizing this extremely important event, RMU, APPNA and HEC. I think Jaleel has covered most of the things, and you can see each institution that has family medicine and general practitioners are full in this hall. And that shows our commitment to family medicine. What was said by Zafar regarding the GPs and the malpractice that may be happening, where do we correct that? That starts from the undergraduate. That's when we need to build up family medicine. Until we introduce it into undergraduate, until that policy by PMDC and PMC doesn't come out that we need family medicine in undergraduate, there is not going to be a change. And in order to produce it in undergraduate, we need to develop supervisors. And where are the supervisors coming from? Jaleel has just talked about all the graduates who are already there, MCPS, FCPS, MRCGP, diploma. All of them can be trained as supervisors and be given the opportunity to sit Part 2 training for FCPS with exemption of Part 1 FCPS. Thank you.
Dr. Adil Heder, Dean, AKU.
Assalamu alaikum. आप लोग इतने सारे स्टूडेंट बैठे हैं. Assalamu alaikum. How are you doing? There you go. ठीक है ना? देखिए मैं 2 मिनट से ज़्यादा लूँगा, Dr. Usmani. I have 2-3 points to make. First is I want to tell you a story. मैं अभी last year अमेरिका से पाकिस्तान मूव हुआ, ठीक है? And when I got to Pakistan, I was very grateful कि I got a whole household staff. अब उस staff में मैं आपको पूरा details नहीं देता, मगर समझ लें एक चौकीदार है हमारा, उसके पास health insurance नहीं है क्योंकि वो contract basis पे काम कर रहा है चौकीदार, ठीक है? Now he needs some healthcare support, and I'm like, oh, I will cover anything you need for healthcare. क्योंकि मैं अभी अमेरिका से आया हूँ, ठीक है? I feel like we should do this for everybody. So then he has a headache, he goes to a neurologist. Then he has some other problem, he goes to a cardiologist. Then he has another problem, he goes to another specialist. अब वो bill पे bill आ रहे हैं, मैं देख रहा हूँ, oh my God, I don't know if I should have made this commitment, right? And then finally, I asked one of our family medicine physicians to take a look. And all of the issues that this poor man was having were easily connected and easily managed and fixed, not by those 3 specialists, but by a family medicine physician. If you think about the economic impact of how this impacted me personally, you can just imagine the economic impact of what's happening in Pakistan, where all of these things are not being taken care of by the correct specialists. And that's the first point I wanted to make about the impact on the economy. The second point I want to make is jo abhi baat ho rahi hai about creating 160,000 family medicine practitioners. There are very simple solutions to do this. One such solution is this thing called the Family Medicine Essentials course that our Department of Family Medicine at Aga Khan has initiated. Now remember, Aga Khan ki Family Medicine Department is the first family medicine department in Pakistan. It's more than 25 years old. And that's a good thing to do. That's a good thing to do. And they are using blended learning. If you have a family medicine general practitioner who has a busy practice, they cannot leave everything that they have and come take a year off to do some sort of course. But by doing a blended learning approach where we use technology to ensure that quality of care improves amongst people who have big practices, right? That we think is a very good way to improve the quality of care. And our hope is that this Family Medicine Essentials course could eventually become a diploma course or something where we can improve the quality of care for people in Pakistan and of course support the family medicine specialty. And the third one is directed towards all the people in the back. आप में से student कितने हैं? बहुत सारे student हैं ना? I am thrilled to be here talking to you because this kind of conference, and I want to congratulate HEC and APPNA on raising the level of family practice. You see, unless we do big congresses like this, unless we, give the proper appreciation to family medicine, we will not be able to achieve the goal of graduating more people in family medicine. And I hope, मेरी hope है कि आप में से बहुत सारे जो यहाँ पे हैं students, you will see this conference and you will think about doing family medicine as your career. Ye meri aap ke liye sab ke liye dua. Thank you so much.
Now I would like to invite Professor Asha Javed, Vice Chancellor of Pebble Medical University, to give his comments.
I'm not a primary healthcare specialist. I was trained as a pulmonologist, and when I came back to Pakistan, I saw that within my specialty there's a major public health problem, TB. So from the day when I came in till today, 30 years, I've devoted most of my time to TB control program and control of TB and MDR TB. But as the luck would have it, when I was appointed as a Vice Chancellor, a day before I took over the charge, I was invited to a meeting sponsored by WHO and the Federal Ministry of Health about this primary health care. And the WHO gave us the target that in order to being a signatory to SDGs, the government of Pakistan is committed to comprehensive health care. And for that, we cannot actually provide universal health care without adopting family health approach, which is recommended by WHO. And the Pakistan government is putting its efforts in the form of, as we just heard, Sehat Sahulat Card, etc. These are some of the initiatives to get to this universal health care. But the shortcut that we were told at that time, that we need, at that time we were told 66,000 family physicians, but now perhaps it's more than 100,000 that we need. But the issues in Pakistan, well, that meeting was focused on universities, that universities are basically the places where they have to take this task and responsibility to train family health physicians or primary care physicians, because Cpsp, as I know, I'm a Cpsp, remain Dean of Pulmonology, but you could see that in 27 years, from Jalil's slide, we saw that only 96 FCPS in family medicine were produced. And I'm sure most of them, because of no recognition and reward, many of them perhaps have left the country. So the contribution of Cpsp, with all due respect, of course Cpsp is the flag bearer of specialist care in Pakistan, but in the area of family health, perhaps it hasn't contributed as much as it could have. So here now the emphasis was on the universities, and we were given the target that within 1 year we have to start this blended program. A curriculum was developed by WHO in collaboration with American University of Beirut, and then the curriculum was sent to Pakistan, and all the family health stakeholders have gone through it and adopted it with some modification. So Heder Medical University, on the very first day I was given this task, and perhaps many of you would not know the bureaucratic processes of the universities, but thank God, with the help of our faculty, we were able to develop Department of Family Medicine in KMU. We were able to approve the curriculum of family one-year diploma in family medicine through our academic council and syndicate. And we were able to create jobs, posts through FNPC and syndicate. And we were very lucky that we got three very able family physician experts in the form of Dr. Jalil, Dr. Kashif, and Dr. Javed. And within no time, and our provincial government also took great interest, that when we advertised for the first batch, we were apprehensive that perhaps no one would apply, because everyone wants to do neurosurgery or cardiology or pulmonology. And in universities these days, very popular programs are health professional education and health research. So we were a bit apprehensive that perhaps no one would apply, but we were surprised that twice as many people applied as we could afford to have. So our first batch started with 40 students. What health department did was, rather than taking randomly people from everywhere, they asked us to, as a pilot, we got all the BHU medical officers of 2 districts as a pilot. So district of Swabi and district of Haripur and district of Khyber. All the medical officers of those BHUs were selected in the first batch. So not only that they were trained and 1-year diploma, but they went back to their districts, and I'm sure we will be assessing the impact on the health services after a while when they have started family health practice approach there. So the second batch has started. I know it is a difficult area. As we saw, that there are a lot of challenges. There are regulatory challenges like duration, like recognition, faculty. Then there are challenges related to institutional capacity. We hardly have any capacity. Not all the universities have family health departments in them, let alone the medical colleges. Yes, PMDC did say that every medical college should have a family health department, but they haven't given a curriculum to those medical colleges for family health. Undergraduate and postgraduate, there are different pathways that are going on as far as family medicine is concerned. Continuous professional development, there's hardly any, although in Pakistan we lacked this area, but now in the clinical subject there's a lot of emphasis on professional development. But is there any professional development facilities for our GPs who are practicing, just learning, as we heard our Honorable Minister, that they get the job or they start their clinic in the general practice, then they learn from their practice from themselves, or at the most from the pharmaceutical companies who guide them or misguide them to prescribe this thing or that thing. So we have a lack of capacity in professional development of our family practitioners. So, and there are financial challenges for the family practitioners. Why would somebody adopt a family physician pathway? Why not a neurosurgeon or orthopedic surgeon? So of course, we have to all think about it, but I'm so happy that this is one of the most important areas that our country should have focused on many decades ago, but better late than never. And today I saw, with the presence of the minister, our task force member, Faisal Sultan, who is one of the policy makers of health in Pakistan, and representatives of various universities and APPNA. You know, I'm introduced to APPNA ever since 1977 when they had first meeting in Peshawar. So thank you very much that at least now this very important area has been addressed, and I hope we are going to make it in the next decade or so. Thank you very much.
Thank you, Professor Irshad. So we have young people collecting questions from the audience. If you could kindly give them your cards with the written question, and I will prioritize it. I will pose some of the questions that were collected in the pre-conference workshop, and any one of the panelists can answer. You will have a minute to answer the question. And if somebody wants to give the feedback, they'll have, the second answer would be 30 seconds. So the first question is, what is the better terminology? Should we call it primary care or family medicine? These questions were collected from the family medicine experts and stakeholders. So what is the better terminology? Primary care or family medicine?
Is it on? Can you hear? Okay. So what does the audience think? Is it primary care or family medicine? Family medicine. Family medicine is what we're talking about. Primary care encompasses a much larger area. It includes nursing, it includes internists who can be primary care physicians as well. It can be general pediatrics, which can be primary care, but family medicine is family medicine, where we deal with 90% of the problems. Agreed?
Can I just expand on that? You know, masla ye hai ki jo family medicine hai na, they're very modest people, okay? I think you should call yourself not family medicine, you should call yourself family medicine specialists. That's what you should call yourself. Because you really are specialists, and you should always like add the specialist thing to it.
Okay, thank you.
My quick answer would be, the person will be called a family medicine specialist, the specialty will be called family medicine, and the service they're going to be provided will be a comprehensive primary care model led by a family medicine specialist.
Thank you. Second question is standard of care for the basic health problems. What are the minimum standards of community-based outreach centers? What should they have available in terms of structure? What kind of accreditation body for appraisal, revalidation, and accountability of these is needed?
So, the basic elements of any family practice or primary care center, I think the essential health package is addressing that in making sure that it's led by a family doctor with the skill of managing most of the problems, with the equipment, with the resources. There's a whole actually document on that by the government now. Dr. Faisal, is that correct? Are you involved in that? In the essential, sorry. Yeah, sorry. So the essential health service package.
Look, I'm not directly involved with the essential services package, but there has to be something that is defined, because you can't cover, at least at this stage in our development, we cannot cover everything. And I think a basic set of package needs to be developed. And it is there. It's already there. There's nothing terribly strange about it.
I'm just going to add, the essential health service package is there in every province. Now the HSA, I think people are sitting here, they've already developed a DCP plan, that's what they call it. The package is good enough, but what my suggestion would be, once you've got the service led by family medicine specialists, you need to then even enhance that package, because we can do a lot more than what is already in the package. The package is being made for the current situation, which is primary care doctors, but once it's been led by the family physicians who are going to be an expert or is going to be a specialist, they will be able to even provide enhanced services. So even you have to upgrade that.
So just one, sorry. With regard to the accreditation that they were talking about. So I'm telling you, it's going to happen. We are going to be having family medicine in undergraduate, and when that happens, we need training sites for our students. And where do we get these training sites? That's where the accreditation will come in. Unless you meet those basic standards, we will not be using those general practice sites. So that's another point of accreditation.
So does Pakistan need to establish a primary care directorate similar to national NHS trust in England, and have state level representation from everyone? So do we need an accreditation council for family medicine?
If any other country in the world can match or adopt the NHS model, I'll congratulate them, even European or American. Of course, we should aim for that, but we are far too away. I think what limited targets we have been given, I think we should better concentrate on those. At the moment, we should focus on this blended program of one-year diploma and try to produce few thousand family specialists within next 5 years, so that the ball gets rolling. Otherwise, yes, NHS, those who know NHS is a brilliant model, but obviously to finance that model, Pakistan does not stand anywhere to even think of that.
I think this question was a lot, I think, raised by a lot of our family medicine experts. The reason they mentioned National Family Medicine Committee was because as we mentioned, Faisal Sab this morning mentioned about DHAs, RHAs, and there are specialists from medicine, there are specialists from obs and gynae and surgery. The problem is, I'm sure you guys know this, in hospital administration or secondary tertiary administration, there is a lot of involvement of the consultant physician by themselves, like our VC Sab has been LRH chief executive, like Faisal is the chief executive of Shaukat Khanum. But if you go into primary care or family medicine, there are no doctors who are qualified in family medicine. Our primary care administration is mostly DHOs and whatever DGs and stuff who are not by themselves family medicine clinicians. So my suggestion would be, if we develop this National Family Medicine Task Force, or even in the current regional health authorities or district health authorities or the Prime Minister Task Force, if there is a representation of National Family Medicine experts, or even in future, because this is a new task we've been given and we're going to work on, so even if we can incorporate members of APPNA's, FCUK, APPNA, a lot of people who come from UK and who wants to contribute, so if we make one similar sort of group, which is the National Task Force on Family Medicine implementation, and they can then look after the process, like how we're going to implement it in the next few years. So that's our suggestion, but let's see.
Thank you. So I have a lot of questions. One of them is obviously, what is the proper nomenclature for people trained in family medicine or are grandfathered in? Should we have 10 different diplomas, you know, an MD, an MS, diploma versus MCPS, FCPS? What should be the national policy as we get on a national program of training? Dr. Adil Heder.
Sure, thank you. I think that there's a multi-phase approach. The first phase is to definitely ensure the quality of care that's being provided by current practitioners who can be grandfathered in. And that's where this kind of a blended diploma program, a one-year program where you work on guidelines, work on management of common conditions, and you help people adjust to doing that. That's I think, one strategy. The second phase approach, I believe, is the MCPS approach, where you do 2 years of training. But within that, I think you need to have an urban versus rural. In the rural, or you could call it the Global Family Health Specialist track, the way we would approach that is that those specialists could do certain procedures, for example, minor surgical procedures, because that is essentially needed out in far-flung areas. And then, of course, the third tier are those who do FCPS, do 4 years of training, and they would be the people who lead this academically and continue to enhance the specialty and advance the specialty. So I would propose a three-tiered approach, includes grandfathers, includes acute need, and then, of course, the more advanced folks.
Thank you. Yes, Dr. Andrade.
Just to add to Adil's comment, I agree 100%. At the moment, as we said, if you want 3 trained family physicians for 10,000 population, how do you get them? You have to have multiple different tiers of programs at the moment. And that is just like in UK. Initially, the general practitioners were grandfathered into the MRCGP. And that went on for 10 years. And once there was enough, there was a huge volume of trained family physicians, then that program was finished. That's what we need at this point in time in the country.
Thank you. The next question is for Professor Asha Javed from Professor Saira Afzal at King Edward Medical University. What is your opinion for better capacity building and developing frameworks for quality training and audit mechanism of primary care physicians?
Well, this question should have been for experts in primary health care. I'm just a poor pulmonologist and then maybe an administrator of a hospital or university. As I mentioned, we have a lot of issues of capacity. Just the question before, what 3 models you mentioned it is exactly according to our PMC or PMDC levels. It is 2A, which is less than 2 years, and 2B, which is 2 years program, and level 3, which is 4 years program. So, to be honest, when I think of level 3, FCPS, do we have a capacity anywhere to train level 4 specialists in primary care? You know, like Cpsp goes and inspect a college, a hospital, whether they have enough capacity to train neurosurgery or cardiology. So I'm wondering whether we have the capacity to train FCPS in any of the hospitals, or we have to develop some centers in the universities or in public-private partnership models where we have enough clinical exposure to these graduates or postgraduates. I think we have to work on developing our capacity. And of course, the audit mechanism then, again, it's, once we have this going on, of course, there has to be clinical audit, financial audit, or whatever. I think that's all I can give answer to your rather difficult question.
Thank you. Any comments on that? Yeah.
I think when you come to the capacity, the family medicine training is kind of, the current is 3 to 4 years of FCPS and MD. So most of the training going to happen in the hospital who are already recognized for FCPS training. So they can have most of their rotation in hospital. The only rotation they need to have it in family medicine going to be a 1-year training at the end of the 3 years which they spend in hospital or after their IMM. For that, yes, certainly we need to develop some capacity. One possibility could be, like Indus Hospital does, I keep giving their example because in them, most of the tertiary hospital are gatekept by the family medicine departments, just like Indus does. So any patient who come to the hospital, they have to go through the family medicine clinic. AKU have the same position. And I think in LRH, Lady Reading Hospital in Peshawar is now in process of starting a family medicine department. So FCPS people we are able to train. The question is only, the previous question was related to this, how we going to get these trainees. So yes, grandfather rule, if we give a little bit relaxation, like people who have already done MCPS or even diploma, any program, because we have to train a lot. So we give them a little bit relaxation, just like in any other specialty. I'm sure Professor Asha Javed would agree that in pulmonology, in some districts, they still give jobs of district specialists to people who have done MCPS in pulmonology. So similar rule can be applied to family medicine. Once we have enough workforce with FCPS, then obviously we're going to implement that. But for now, if we give a bit of relaxation to these students who have done either a diploma or an MCPS, if they give a little bit relaxation in the going into FCPS program, some of them may do it, some of them may not do it. So at least level 2B should be the prerequisite. Level 3 is already a prerequisite for faculty positions. So those of them who are motivated to do it, they should be given the opportunity. So I think that's what we need.
Thank you. There are two questions similar about private-public partnership. So one of the questions talks about how there's a lot of red tapeism in government institutions, and to promote family medicine training programs, it will be better in a private-public partnership setup. How will government determine the incentives and quality control in this private enterprise-led family medicine? So how do you impose those standards in the private-public setup?
Okay. So I think, and this relates to the question that was discussed a little bit earlier as well. Fine, there is a need and desire to have primary care physicians or family practitioners, or call what you may. That's understood. We could even agree on what the basic set of, or what the basic skill set is, which has been sort of talked about. But who certifies it? So far, in Pakistan, all medical and medical graduate and postgraduate qualifications have been certified by the PMDC or the PMC or, you know, a central body that looks after this sort of thing. I think that one would have to have some standardization of doing this. Now, the other part question in there is that if there isn't enough appetite in the public sector to do it, why not get the private sector to do it? I think the private sector is doing it. You have an example right there. The Aga Khan University started this thing way before anyone else did. So I think nobody is stopping any entity from doing it, but what we need to agree on is exactly what qualification it would be, what it would include, and who would really have oversight into it. We already have a little bit of trouble and push and pull in the specialist sector between the university degrees like MD, MS and the Cpsp. And I think it would be best if at this stage we paid some thought onto how to do this going forward, because I already see a lot of polarity and at times even animosity between the MD, MS world and the FCPS world, and I think we should do some homework to make sure that this doesn't happen for family medicine.
Yes, Dr.
Thank you for
Heder.
those comments. I want to thank you and acknowledge all of the folks who've been talking about Aga Khan's program. The good thing about technology is that the chair of the Department of Family Medicine, who's sitting right there, Dr. Unab Khan, she texted me to let me know that हमने 106 graduate किए from the program, of which 98 have passed their FCPS and 8 ended up doing MRCP. Now, 87% of healthcare in Pakistan is delivered in the private sector. 87%. So your question makes a lot of sense. This has to be a private and public partnership. And to promote such a thing, I've gotten a text from our department chair, and she is willing to work with everybody here. All the stakeholders of family medicine are here. And she has that family medicine essentials course. The minister was saying we should have like one course. She's willing to help it, abrogate it, change it, work with everybody to make one course that everybody could use. And we're willing to do that like today.
Thank you, Unab and Adil. I know that I was part of that course in the beginning and it was really good. So we have actually been working, the public sector universities have been working to develop one common diploma of family medicine, which is obviously has the same commonalities as the course at AKU. It's also a blended learning course with some contact hours and skill development. So hopefully this course, which is also going to be part of WHO, is going to be spread across the country in multiple universities, especially the public sector.
I think the question was twofold. One was training of public-private partnership. Definitely we need all the universities. So what Mary talked about, the diploma at Heder Medical University, that diploma is being developed, and it's not by Heder Medical University. It is WHO diploma, and it's called Regional Diploma WHO for Pakistan, and it's got accreditation of WHO and WONCA. So it's not, any university, including private, can adopt it, and we've been working on strengthening the online component. Bear in mind that most of the primary care physicians have busy time and they can't do that. So that bit, we agree on it. Obviously, University of Lahore is a private institute and they have kind of agreed to join. That's one bit. Yes, we can sit together, we can design one course, that's not a problem. The second part of the question was public-private partnership in terms of providing the primary care services. So I think I can see one of my colleagues sitting here from an organization called MERF. They're doing a lot of work in Sindh and now in Khyber, FATA. I always get confused with the name. It used to be FATA, but now it's KP merged district. So it's a part of KP. So what they're doing is they're providing care in secondary hospital, and they've been working on getting the contracts for the BHUs as well, and they can make it one cluster. In the past, PPHI provided that as well. It was an organization who provided the care. Again, in a lot of, it's a district called Dir. There's a lot of, in Chatral now, AKU has been granted the contract. So in public-private partnership, they can provide. But we need to control them. Control number one, we need to only give the contract, Professor Sultan Sahib is sitting there, once we know that they've got family medicine specialists who are going to be providing the care, number one. Number two is we need to design a care quality commission UK type strategy to keep a control on it. not just IMU, because in Pakistan what happened, they just check quantity, how many doctors you got, how many nurses you got. What we do in UK, what we do is we assess, is the service accessible, is the service caring, is the service responsive, and is the service effective? So certainly if the government just regulate them and contract it out to public-private partnership with some legality that they need to have family medicine specialists, and they have to have quality assured, like quality audit and stuff, so they can do that.
So the next group of questions that I've gotten from the audiences is about the financial reimbursement or financial compensation from family physicians. One question is, what is the future of family physician if the current conditions remain the same? How are you going to motivate new graduates into becoming FCPS trained family medicine specialists? And what kind of financial assistance is being offered to the training in these courses? And the third question was that what is the difference if you are working as a family physician in a public sector versus private sector, and what are the incentives? So all three are related to compensation and incentives.
Incentives, first we'll start with incentives for the trainees. If I'm not wrong, the first batch or the second batch who are now being trained in KMU, they are training on their own expenses. Yeah, they're paying, they're not being paid any stipend, which is other way around if you're doing FCPS. In FCPS, you don't pay anything. You're being trained in a tertiary care hospital. And I don't know about other provinces, but in KP, you're very generous. We give them around 100,000 rupees stipend, even if they work in private medical college or private hospital. The government of KP pay their stipend. We wanted to encourage the post-graduation, especially in very specialties which are badly needed. So here, unfortunately, it's the other way around. There's definitely need for incentivizing. Otherwise, you know, in our first batch, we were lucky we got all the already working medical officers in the health department. One of them is sitting here. Yeah, they were already working in BHUs. I don't know what their incentive was. Maybe that they will have more job satisfaction when you go back to your BHU. I think we need to inculcate into their career that if they have done diploma, their promotion is enhanced or expedited, or they get some extra incentives monetary-wise. I think this has to be included. Otherwise, we cannot actually go.
I think, interestingly, the financial model is already there. We just need to connect one little thing. Adil said 87%. The most conservative estimates even of healthcare delivery are 70% in the private sector. So let's take that for a moment. You know, let's assume Adil is wrong here, although I think he's got much more updated figures. But even at 70%, which means that 70% of healthcare delivery is being done by the private sector, it means the business case is there already. What we need to do is connect this reimbursement by the government, which currently is the Sehat card, to connect it to the private providers. And I think the biggest incentive would be that this could get connected only if you met certain criteria. And amongst those criteria must be one, qualification or training, and the second, allow yourself to be monitored. I think if you do these and connect this, there'll be an immediate connection. Lastly, to finance, getting there, I think the health foundations, there's the Punjab Health and others, already have that inbuilt mechanism of allowing practitioners who come into practice to set up their own practices to get going. And this is a very personal last statement, it's got nothing to do with anything on an official level. I feel that a qualified physician who's out there would rather not be employed, but rather be working on their own, but be reimbursed in a proper way through something like the Safe Card.
I was just going to build on what you're saying, Dr. Faisal. You know, there are a lot of other models where there's some sort of shared incentive. So if for taking that thing with the Sehat card, if you're getting paid because of the Sehat card, you can also add that if, as a family physician, your patients are meeting certain benchmarks, many places have very simple things, hemoglobin A1C for people who have diabetes and so on. That if you manage your patients well, that they're all meeting certain benchmarks, that you get an incentive around that. So there are many ways to improve healthcare, which will decrease the overall cost of healthcare. Because that's, you could save a lot of money from the overall cost and then transfer that to better incentivize the practitioners. And that's a much better use of that money than just wasting it.
Just want to add one thing. That's for private, as Faisal said, and Adil, that I agree with it. The only thing is, doctors who are already working in primary healthcare centers, the only incentive for them would be, like, if the government kind of agreed to pay their fee, at least, or even that time off, at least, because now currently we are struggling. Our students are not even able to get time off because there is either a polio campaign running on, there is either a MMR campaign going on, something is going on, so they're not even allowed to take the leave. So if the task force at least allow them to have that leave, and at least for the pilot districts where they want to implement the model, at least to pay their fee or just one salary extra or something, they do get bonuses and stuff. For private, as Faisal said, yes, incentive could be set, Sahulat card, but for the public sector, something like, helping them getting that training or even getting them transferred to near the university or near the location where or even getting them, just like any other specialty,
or
they
online.
get transferred and then go back.
Yeah. So I have two questions which I am assuming is coming from the students. Why are doctors not showing interest in family medicine? If someone is supposed to complete post-graduation like MCPS or FCPS in family medicine, what incentives government will provide? Second question, an MBBS graduate curriculum should be reinforced with PMD standards for a well-rounded general physician at the end of 5 long years of expensive education that is not directed towards primary care.
So thank you so much for such a relevant question. Why are students not interested? Well, they don't know about family medicine. It's not there in the undergraduate. At Jinnah Sindh Medical University, we were trying, and in fact next year it's going to be implemented in 5 medical colleges across the country. But what I was saying is that in Jinnah Sindh Medical University, we thought, now how do we get students to actually get to know about family medicine? And what we introduced is, at the time of admission of first year students, we did their pre-admission medical. And when they went through, all of us 350 in Jinnah Sindh Medical University, they all knew what family medicine is. Because we screened them, now they come to us for the health issues, they know where family medicine is, they have seen where it fits into the health system.
So I want to ask, there are lots of medical students here. आप सारे medical student हैं. आप हाथ बढ़ाएं. अगर आप surgeon बनना चाहते हैं, या cardiologist बनना चाहते हैं, हाथ उठाएंगे. है ना? बहुत सारे हैं जो बनना चाहते हैं. It's because of a disease that we have amongst the medical students. उसका है मतलब ABC, anything but clinic, right? Nobody wants to sit in the clinic. Everybody wants to go do the cool, very cool interventional specialties. That's a big problem. Because what happens is the students never get exposed to the joys of practicing clinic, the joys of having a long-term relationship with the patient, many of the things that you get in as a family medicine specialist. And that's why 20% of our curriculum at AKU has always been devoted to community health, and in all of the years we have devoted rotations to primary health care, right? And I think we should give a round of applause for that. This is the way you create people with excitement towards family medicine specialty.
So I'm only supposed to talk about the questions, but I work at University of Massachusetts, and it's the top-rated medical school in USA that provides primary care education. So it's top-rated for primary care education, and that in itself brings a lot of applicants to our medical school. We also give scholarships to people. We write off their tuition, which is extremely expensive in USA, if they are willing to serve in a rural area, underserved area for a couple of years. So a lot of people, because their tuition is going to be waived agree to that 2-year period that they have to work in primary care setting. Thirdly, every single student at the start of first year starts having a clinical attachment, what we call longitudinal preceptorship program, so that once every semester there are 5 or 6 clinics they have to attend in a primary care setting. So they learn how it is to be a doctor straight, get-go from year 1. They learn how to do examination, taking histories, writing prescriptions, etc. By the time they reach 3rd year, they have had 2 years of experience working with a seasoned clinician. That's how they know what primary care is about. Okay, next question is for Dr. Faisal Sultan. We cannot improve primary care delivery system until we eliminate the quacks. What's the policy on the ground, Dr. Syed Asad Ali?
You're asking me?
Yes, directed to you.
So yes, I think the policy is there. It's really a question of implementation. The healthcare commissions have been at it. They're trying to, seal and close clinics. The problem is they seal one and the other one opens, or the same one opens 2 streets down. I think part of this also has to do with how the healthcare system itself, or how practitioners themselves, or how we as providers of care differentiate ourselves from quacks. Because at the end of the day, enforcement is only part of the game. The rest is the ability of the formal system to be able to differentiate from what they're offering. So I think that is partly our own responsibility as a profession. And obviously you realize I do not speak for the government. My role is only advisory on the task force. But I am aware, and I can tell you that the healthcare commissions constantly do look at closing down and coming down on unregistered, unlicensed, untrained practitioners. But it's a question of constant enforcement. Nobody can be in every little gully and mohalla every single day. I think part of it is we as a society need to also be aware and create a pressure that only those with proper licenses and proper training should be practicing.
So there are many more questions, but unfortunately we have run out of time. I will ask the chair of the session for closing remarks, and then we will break for lunch. The questions that I was not able to pose, we will ask them in other sessions. Thank you.
Thank you, Dr. Nahid. I think there's really very little to say other than that this is very topical, very current, very important, and to me, and I still leave this as a question to my panelists and colleagues here, how do we create the prestige and placement of this in society to allow young men and women to preferentially choose this as a career? I think this is where we end up failing. It's not so much money. I think you constantly spoke about recognition. And I think this is a thought for all of us. And those that think deeply maybe will come out with something better than what we can do in a very quick session, is how do we actually bring that prestige, that placement, both for physicians as well as for nursing. I think all these things that Dr. Adil mentioned, in which we prioritize more money and procedures and quick short solutions, and we are out, so which means most surgical type or procedure type specialties get prioritized high. How do we do this? It's not just money, but it's what society places prestige and importance on. Something to think about as a common body as well. Why is it that we end up placing all the glamour on things that are short, sweet, more well reimbursed and provided for? So I think we, again, just like my earlier response, I think we as a society also need to take ownership of this larger problem, where we need to emphasize that some ordinary, simple, below the radar work sometimes has much more impact than some of those more glamorous kind of actions. Thank you very much.
I thank the chair, all the panelists for a very good session. Please, if everybody goes for lunch, and then we meet again